begin our first scientific session with an exceptional lineup of speakers and a powerhouse panel. I request Dr. Chitra Ramamurthy ma'am, Dr. Ellen Kumaran sir, and Dr. Anujit Paul sir to please welcome on the stage. Dr. Chitra Ramamurthy will be the moderator for this session.
Good morning, everyone. Right at the outset, I would like to thank Dr. Sri Ganesh and Dr. Supriya and the team Netradhama for having me here. We all know that cataract surgery has evolved tremendously over the years. But amidst the technological progresses, one thing remains constant, and that is our patience. Today's talk which I am giving is about something very simple, yet which is very often overlooked, truly understanding our patients. So basically, learning the patient involves understanding what our patient needs are. We need to know their hobbies, their work, their lifestyle, whether they drive, the sort of profession they are in. And how does this help is because when we learn our patients and their lifestyles, their expectations and personalities, we lay the foundation for successful outcomes. Because when we learn our patients, it's something which always is important because we can deliver better results after learning them. So why is it important? Because every eye, as you know, is different. But what we don't realize is that every person is also different. So when we learn our patient, we can customize our plan. So learning the patient matters because it helps to build long-term trust and set the expectations right. And this helps in reducing the post-op dissatisfaction, which many of our patients often have. This not only improves the surgical outcome, but also prevents dissatisfaction and drives more direct mouth-to-mouth referrals. So what does learning the patient actually involve? We ask about their hobbies. Do they read a lot, drive at night, or spend time on digital devices? Are they looking for independence from glasses, or are they comfortable using them occasionally? Understanding tolerance to visual phenomena like halos and glare also plays a big role. A simple, structured history can often tell us more than very often complicated investigations can tell us. Once we have a patient profile, the IOL selection becomes a targeted decision and not guesswork. Monofocals for the low demanding patients, EDOFs for those who require intermediate vision, torics for the astigmatic, micromonovision for balanced vision, the right lens for the right patient, not always the most expensive lens by default. So preoperative counseling is the actual moment of truth. We must clearly explain what each lens can and cannot do. And we need to be frank with the patients regarding this. Visual aids and videos can help clarify this. And the most important thing is to document the patient's expectations. If they want to throw away their glasses post-surgery and you plan a monofocal, I can guarantee you there will be a lot of trouble post-operatively. So basically, preoperative counseling helps to build a rapport with the patients and set realistic expectations. Coming to the next stage is in the operation theater also, the personalization continues. Incision placement, toric alignment, IOL centration, all these need to be fine-tuned. Some eyes may benefit from intraoperative aberrometry or a customized incision. Learning the patient means respecting their eye anatomy too. Post-op is not a goodbye. It's where the reassurance and supports matter. Ask how they are feeling and not only how they are seeing. Small adjustments or simple listening can prevent a dissatisfied patient. A follow-up call after surgery can do wonders, and one needs to pick up early signs of dissatisfaction. These patients need to be taken particular care of, and very often we would even see these patients without any follow-up charges for a long period of time. This shows that we are not only bothered about their outcomes, but also help to try and counsel them to get over their dissatisfaction. Post-operative care helps to keep the bond strong, and it's also important to continue the post-op patient education about what they should and what shouldn't do. A few examples here. is learning from clear, real life situations. So this is a 70-year-old male golfer who had a high visual demand for distance clarity. So the choice of IOL here was not bothered about wearing glasses for near vision. So the choice of IOL here was a monofocal IOL targeting emetropia. And this patient had an excellent outcome and resumed golfing within 3 weeks. Another patient, a 60-year-old banker, spending hours on the screens, and EDOF IOL here helped him to get over the problem of the intermediate as well as the distance vision. And this patient usually would drive at night, and therefore a trifocal or a multifocal IOL would not be a good choice. Again, a patient, a 55-year-old housewife, an ardent mobile user who enjoys embroidery. So this would be a patient, and who rarely drives at night, would be a good choice for a trifocal IOL. So the concept of personalized cataract surgery isn't a new one. Lunstorm and colleagues emphasized patient-reported outcomes. Holliday talked about the importance of quality of vision. Cohen discussed profiling, and the Indian literature also supports this. So this isn't anecdotal. It's basically evidence-based. To conclude, great cataract surgery isn't about phaco power, setting vacuum, or the IOL types. It is basically also the connect with the patient. It's about aligning our surgical choices with the person sitting across from us, because when you treat the patient and not just the eye, you win their vision, their trust, and their gratitude for a lifetime. So in conclusion, I'd like to say that success would involve not only happy eyes, but also happy hearts. Thank you for your kind attention, and I hope this talk gave you a fresh lens, pun intended over here, on how we can make a cataract surgery more personal and more powerful. Thank you once again.
Thank you, Dr. Nitin. Just a question for you. So I think when we talk of perfecting, now with the way the biometry stands today, we are able to reach to this target emetropic outcome in good majority of our patients. But do you believe in having just one go-to formula, or you'd like to have 2-3 formulas before you choose the IOL power for your patients? Or
a comparison of the various formula, I think, is very, very important, because very often certain outliers would not do well with one formula. So it needed to compare the results from a different formula.
And talking about intraocular lenses, do you actually ever believe that there's a concept of mixing and matching the IOLs, or would you rather just do a micro monovision if need indicated? Or
a micro monovision helps if the patient is not very keen on perfect vision for both distance and near in individual eyes. Again, one should remember that there's a loss of stereopsis, so patients in whom stereopsis is very important, I wouldn't go for a micro monovision. Mixing and matching, today's era, mixing and matching is not something which we have been doing a lot. There are some lenses which come with different light distribution for different distances, like Hoya has the Geometric and the Geometric Plus. I wouldn't actually call them a mix and match, basically, because they've got the same additions for intermediate and near and same principle. But then that is the only place where I use a mix and match nowadays.
do you have anything?
So excellent presentation. Just to add something in patient counseling, what I felt that worked for me is that I make it routinely a practice to offer all types of lenses to all types of patients, not only at the level of my counselor or optometrist, but even if they have chosen a lens or they know someone who's taken a lens which they are comfortable with, I make it a point to offer the lens to them. I tell them that if you go higher up on the ladder, I can give you clear distant vision along with some clear near vision, just in 2 sentences. And sometimes for me it works very well when they are offered the choice and maybe they think about it and they come back and they say that, okay, I've rethought my IOL, I've rethought my surgery, and I would like to go ahead with it. So for those starting off with their practice, the easiest way to start off upgrading to 80 IOLs is to just treat every patient as a potential 80 IOL patient and offer the lens. If they do not know about it, they will never choose it. That's just 2 cents.
Absolutely true. The one thing which I would like to point out here is You mentioned about patients mentioning about the lens which someone else whom they know have. I make it a point to dissuade the patient, tell him that it has to be horses for the courses. So it's not something because your friend or your relative had. And also, it's not something that, there are some patients who would come in, like Sri Ganesh was telling me last night that there's some patients who come and want to show off their wealth. And they would come and say that I want the best and I want the most expensive lens. Well, the most expensive lens, so I give them a small analogy as in Bombay with all the potholed roads. I tell them that would you buy a Ferrari and drive it in the city of Bombay, or would you prefer a Honda City or a Honda Accord, something of that sort, you know? So it's something which suits you individually, and this is where customization and personalization is very, very important.
Sir, continuing on that point, even if the patient cannot afford, some of the Indian lenses are very good. The example would be the Torics, where they really have a very good outcome. And that was a beautiful talk. When we started topical phaco in 2000, 2001, professors used to say, you go and do the biometry to assess whether this patient would be cooperative on the table. This is a different perspective.
Right, absolutely.
Thank you, Doctor.
Thank you, thank you.
Thank you for a wonderful talk.